Hello, Professor Clark. How are you?
Hello, thank you. Fine. And
Excellent.
how are you all?
You all are good. Good to see you.
Thank you.
Yes, welcome, Stephanie. Always good to see you.
It's a pleasure. Sorry I couldn't make it the last two times, but I had meetings. Yeah.
Stephanie, nice to see you.
Hello.
How are you?
Sorry?
How are you? How are you?
Oh, fine. Yes, we are having eventually good weather. Yeah. Uh,
Yeah. I miss Switzerland. I love to visit Switzerland very soon. Yeah.
We start in 2 minutes time.
Hi, Neeraj.
Hey, Neeraj.
Good afternoon, everyone.
Welcome.
Hello,
You can
Neeraj.
quickly
Good to see you.
check the PPT if you want to.
Neeraj, you want to check your presentation?
I'll just check once.
Yeah.
Is it visible full screen?
Yeah.
All right. Thank you, sir.
Perfect. So we start in 1 more minute. Okay. All right. So, good afternoon, good evening, ladies and gentlemen. Dr. Nirmal Surya, the President of Asian Oceanian Society of Neuro Rehabilitation, welcome you all for this most popular AOSNR webinar series. And today is the 6th of the session which we started right in the July, and we have now by now uh, started from the May. So we had a first session on 2nd of the May, then followed by the 6th June, then 4th July, then 5th August, 5th September, and today on the occasion of 3rd October. We'll have the next session on 7th November. And today's topic is, we started series, starting from introduction, followed by the neuroplasticity, and then followed after the neuroplasticity, we had on the assistive technology, then followed by the cognitive rehab strategy, and the last session was on physical therapy in multiple rehabilitation. To continue the series, today we will have occupational therapy in neuro rehabilitation. What is most important is that we have consistently around 200 plus people from more than 25 countries across the globe, not only from Asia, to be part of this webinar. And we have been getting a wonderful feedback from them that this series has been very helpful. Learning. I know this is a little odd time for many countries, particularly from India. A lot of people complain me that 3 o'clock is the time for them to work in the hospital. But to, balance the whole world, we have been able to get onto a consensus on 3 o'clock. What is important is that we are getting a lot of people who have missed out on the webinar on the YouTube. So we have more than 500 plus hits on the YouTube of Asian Oceanian Society of Neuro Rehab page. And those who have missed out on the webinar, they can always go back and listen on the YouTube and give their feedback. So I won't take much of your time, but I certainly look forward to your comments, your suggestions, and your, expectation from us. I'm very glad that past President WFNR, Professor Stephanie Clark, is here. I'm also very happy to have the past President AOSNR, Dr. Teresita, the President-elect, Dr. Fairy Khan, the Secretary General, Dr. Vitsanu, and of course, the course director, Abhishek, and then the representation from Nepal, Raju, and other people who are definitely there. We already have 117 people now onto the webinar for the live, and we'll share the link on YouTube, which is increasing every minute now. It is 120. So we'll share the link of YouTube to all of you and on the various social media platforms. So those who miss out can be use that for the future. So with that note, I hand over to the chairperson, the Professor Fairy Khan from Australia. Dr. Tisha is going to be here in some time. So Tisha is not here, but he is chair and professor, director, neurology, Western Health, Melbourne, Australia. He is the president of Asian Region Consortium of Headache. And most important, he is the member at large at Presidium of World Federation Neuro Rehab and chair of the headache subsection, headache special interest group at WFNR. Professor Fairy Khan is president-elect of Asian Oceanian Society of Neuro Rehab, very well known in the circle of neuro rehab. She is also president-elect of ISPRM, and she is director of rehabilitation at Royal Melbourne Hospital and Peter McCullum Center, Cancer Center, Victoria, Australia. And she has got many awards, and she has been doing great work across the globe with giving her services for improving the rehab, in particular lower middle income countries. So over to you, Fairy, to take it forward to the speaker.
Thank you very much, Nirmal, and thank you to all the organizing committee for organizing such a successful, fantastic webinar series. So today it gives me great pleasure to introduce to you Dr. Marlena Kleik. I've known Marlena for nearly 15 years, And she is an occupational therapist who's an outstanding contributor to the field of neurorehabilitation. She works at the Royal Melbourne Hospital, La Trobe University, and the University of Melbourne. So today she's going to share with us some of the new strategies, a way forward with how we can introduce and better utilize occupational therapy for people with neurological insults. Thank you, Malina.
Thank you. Thanks, Fari. I'm going to share my screen now. Can I just check that you're seeing my screen, Fari, and you're seeing my presentation screen?
Sure.
Yes? Fantastic. Thank you for the lovely introduction. That was fantastic and very generous of you, Fari. Yes, we've worked together for, I think, 15 years or so, and it's been a tremendous privilege to learn from Fari in terms of research and indeed in neurological rehabilitation. And thank you also to the committee for inviting me to come and speak to you today. I wanted to share a little bit of research that Fari and myself and an entire team have been involved in, and it's around the use of robotics and emerging technologies in neurorehabilitation. But I wanted to go through not just what we achieved, but some of the rationale behind what robotics or emerging technologies can offer us in terms of neurological rehabilitation. So I'll start by going through briefly the clinical background. I believe everyone that's attending have an interest or are experienced in neurological rehabilitation, so I might whiz past some of that because undoubtedly most people will know the background around neuroplasticity. Then I'll talk a little bit about technology, the sorts of technology we might consider using in our clinical rehabilitation practice, a little about feasibility and effectiveness in terms of the results we might see from our patients and their outcomes. And then I want to touch on, if I've got time, a partnership model and how we came to translate our findings into practice through a very successful relationship between engineers, consumers, and clinicians. So the clinical setting. We all know that clinical rehabilitation recommendations, for example, from the World Health Organization, is that rehabilitation should be client-centered. It should include carers, families, and friends as part of that rehabilitation team. It should be goal-oriented, and that's really important. It's important for the patient to be able to know if they're achieving what they wish to achieve. It's also important for clinicians in terms of measurable outcomes for the services that we deliver. And of course, we know it should be based on these concepts of disability. What we want to achieve is improved participation and reduction in disability or handicap. So more functional engagement and societal participation. And interdisciplinary, which of course means that we should all be working on a similar goal. That's not to say that as individual professional groups, we don't think about impairment levels, but those impairment levels should be considered within the context of a goal that is worked on collaboratively across the team. For neurological rehabilitation, we all know that that's a type of rehabilitation that focuses on people that have diseases or injuries or disorders of the nervous system. For myself, my area of expertise is in stroke and brain injury rehabilitation. So along with those other recommendations from the WHO in relation to clinical rehabilitation, we know that neurorehabilitation should also consider dosage. And from an Australian perspective, and I believe this is reflected quite well across the world in other clinical guidelines, we're told that rehabilitation should be structured to provide as much occupational therapy and physiotherapy as possible. So it should be active. We don't want our patients to be sitting around. We want them to be doing as much as they can on a given day. Of course, we need to consider neurological fatigue, but we really need to be providing opportunities for our patients to engage. And from an Australian perspective, again, the recommendation is up to 3 hours a day of scheduled therapy. And roughly 2 hours of that should be active practice, so doing things with the hands and the arms. And the reason that we have those recommendations is it's based on literature around neuroplasticity. And again, I'll just zip past this because I'm sure that everybody understands neuroplasticity, and I believe that there was a webinar on that recently. So we know that there's a lot of spontaneous reorganization in those very early acute stages post a neurological injury. But we know that as time goes on and the injury is more chronic, that to make those neuroplasticity types of changes, that this is largely experience dependent. And by that, we know that patients need to have the opportunity to actually practice the exercise and practice the movement. It's not going to happen spontaneously if patients aren't being given opportunities to practice. So a lot of research in the area of neuroplasticity over the last probably 20 years or so, and I feel like it's in everyone's language. You know, lay people as well as clinicians, we all talk about neuroplasticity. We also know that there are some principles that we need to consider if we're targeting neuroplasticity as part of our rehabilitation. And these are the 10 principles that are recommended to be considered in order to improve functional outcomes if we're taking this approach. So use it or lose it. That's not news to anyone. We know that disuse happens very quickly for our patients. We know that salience is important, so that's around task-specific training. And most important, what we see coming out of the literature, probably in the last 5 to 10 years, is this notion of the importance of repetition and intensity, which we can broadly call dose or dosage. And my gosh, aren't there a lot of publications around dose and dosage and how much do we need and how much will make a difference to our patients. So dose basically means the amount of therapy. And what we mean by the amount of therapy is how many repetitions a patient does in a given therapy session, how many sessions a patient is actually provided in a given week, in a given month, in a given episode, and the length of episode of care. Is it 2 weeks? Is it 4 weeks? Is it 6 weeks? Lots of published evidence coming out on dose, and we know that there's a relationship between dose and effect size. We don't really know how much. Animal studies suggest up to 400 reps result in brain changes, though that sounds like quite a lot. We do know from systematic reviews on clinical rehab that to achieve functional changes, we need quite a few hours of therapy. So that seems to align with those animal studies. And of course, there's this famous quote that it's difficult, and I'm sure that all of us who work in neuro rehab will agree with this, difficult to demonstrate the benefit of rehabilitation interventions because they're routinely delivered at suboptimal doses. And certainly as a clinician researcher and a clinician, I would say, hand on heart, that happens in Australia. I imagine it happens everywhere. So we have what we know as a knowledge practice gap. We know that neuroplasticity is dependent on dosage, that it's dependent on practice and saliency and those other principles that we discussed before. And yet we know, and I'm sorry, this is a little bit Australian-centric, yet we know from audits of services that only 9% of our patients receive evidence-based treatments. In Victoria, less than half receive the recommended intensity or the dosage. And we also know, and there's actually quite a few studies on this, that within a given therapy session, that at the top end, patients usually achieve about 30 repetitions in the entire session. So if they're in a rehab session and it's, say, 45 minutes, they would, at the higher end, be able to achieve 30 reps. And so that's quite a distance from the recommended or the suggestions coming from the research evidence that it's about 300 to 400 repetitions that might be necessary to really see some changes. So technology. Been thinking a lot about technology, and I'm going to go into one of our studies in a moment. But first of all, I want to talk about why we think technology might be a possible solution to achieve dosage or to help us bridge that evidence practice gap. So we know from the literature, not just in Australia and our audits, but certainly globally, that the required dose isn't being achieved. So conventional practice really struggles for many reasons to be able to have deliver that type of therapy. we think that robot assisted or emerging technology might be able to improve accessibility to therapy for patients and certainly for clinicians. And what that means for us, and certainly what it's meant for me, is that my time then can actually focus more specifically on what I want to do with my patients. So a lot of that generalization. If the mass practice or some of that higher dosage stuff can happen using augmentative or emerging technologies, then I can do the hands-on work to shape or be doing some generalization in terms of tasks. We know that in conventional therapy, we roughly get 1 repetition per minute in stroke rehabilitation. And by comparison, we know that with emerging technologies, robotics, for example, the average is 17 repetitions per minute. And we've just published this study that a robotic device that we've developed, and I'll go into that in a moment, is able to achieve 5 repetitions per minute gross movements for stroke patients. And I'll go through the type of robot that we've got there. So we can see that the robotic devices can deliver a much higher level of task practice for the patients. We also know that robotic devices can be available for patients to use if and when needed. And that's really important when we've got high volumes of patients, and it can be really tricky to be providing one-on-one to every patient and trying to deliver the amount of practice that's needed. So our experience, what we've set up is a gym-like or a group therapy model program that's used some of this emerging technology for patients to be able to achieve the practice that they need, but reduce that one-on-one demand from the clinicians, and also to encourage that independent practice. Really critical when you've got therapist shortage. And I think myself, if I was a patient, I'd like the opportunity to be able to practice whenever I could. And of course, we can get a tremendous amount of data using emerging technology. It can be, I have these arguments sometimes with my engineering colleagues in terms of, is it better quality data or is it more objective? I think clinicians are great at collecting data, but sometimes we don't have the sensitivity that some of these devices can give us. And of course, we can set programs using these devices. The clinicians can set those programs so that the patients can then independently enact those programs. So we know, and I'm sure that everybody's aware, that there's lots of studies around robotics out there, and this is a huge market, a growing market. Lots of devices coming out all the time. It can be quite a confusing market as well, and I've popped up some pictures there of some commonly used robotic devices. These are very much first generation robotic devices, and they've certainly been tremendous. I think that these 2 particular devices have been around probably for 15 to 20 years or so. It does have some limitations though. So while these systems have, developed a lot over these last, 10, 15, 20 years, they largely really look at planar movements. So they don't often allow 3-dimensional movements. So we see a gap there in terms of how clinicians want to deliver the therapy, where we're interested in 3-dimensional movement, and what these robotic devices can offer us. And most often they're coupled with on-screen devices or on-screen cursor, which you can see there in those pictures. And that's probably what most of us are familiar with when we're thinking about robotic devices or emerging technologies. And we know from research coming out that there are some limitations for this. So the need for robotics training to directly target all the upper limb segments, so not to separate it out, but to target all of them, and to work on anti-gravity 3-dimensional movements has been a strong recommendation coming out from systematic reviews on emerging technologies. And certainly this is a preference from clinicians. So there's publications when we ask clinicians, what do you want from robotics? They want it to be more like what we would do in therapy. So to address that shortcoming, Fari, myself, and a team of researchers designed a robotic device, and we also had survivors of stroke who helped us design this robot. And it's called the EMU, and it was developed through a user-based design process, which was tremendously useful. And in this period of research where we're all very invested in co-design, it's a great example of how to use co-design to develop a device that has high clinical utility. And this device features, the most important thing that we included in this device, and it's won quite a few awards for this, is that participants can work with real objects. So they can work with screens as well if you just needed to perhaps start them off with that. But if you can have a look at that young man in that bottom photo, he's working with a glass of water and practicing lifting that up to his mouth. So that's pretty novel. We haven't really seen that in many robotic devices. And I have to say that I think it took us about 7 years to actually get that study fully completed across several sites, and the various iterations and designs of that robotic device, and collating all the feedback from all the different users to land on this device that is based on the principles of neuroplasticity. And we've published several papers on that that you can look up, or we can provide you the details. And of course, it's important to be thinking that, you know, robotic devices can be more than just dosage. The significant limitation that we're seeing in the literature on these devices in neurorehabilitation is this notion that they can just deliver mass practice. But what we're trying to do is use it in terms of the neurorehabilitation principles, as well as using it to collect important data and measurements, and to build on top of therapy sessions. So these are the types of robotic features that are coming out of the literature as being really important. So gravity compensation, assistance if or as needed for clinicians to be able to set that up for their patients, being able to do posture shaping, and of course it needs to be motivational. So whether it's gaming, associated with gaming, or task-specific training, or possibly in a group exercise program. And I will talk about the benefits of it in a group exercise program. So let's think about the patient and whether these emerging technologies such as robotics, do they actually make a difference? So the Cochrane Review 2016, I think it's been updated since then. I'm pretty sure it was updated in 2020, consisted of over 1,000 patients, and they found that these devices did improve upper limb function. So how we're using our hand at home and outside of the therapeutic environment. And it did improve ADL function, which of course is really important because people want to be able to do things like get dressed and be able to feed themselves and engage in these tasks that are important. From an Australian perspective, there's been some limitations in terms of uptake of these devices in practice. And how effective they are. A lot of this literature included in this review was based in the US and in other countries. So we haven't really explored how, or we hadn't until we did, explore how feasible it is to use emerging technologies like robotics and other such devices, whether it's feasible for patients, health professionals, or indeed healthcare organisations. So we did a study on this, the Hand Hub study, and our idea was to set up an emerging technology clinic and to look at, does it make a difference in terms of outcomes for patients, and we wanted to know whether it could be set up without additional resources. So this is not a grant funded study. And this was a study that we just embedded as part of practice, and it was a large practice change study. That's another story for another presentation. But we were clever in terms of collecting data as we went along. So the setting and the participants, it was the rehabilitation centre where Fari and I work in the Melbourne metropolitan location. The beautiful thing about this study is that we included all patients that would normally walk through the door for rehab. So we didn't have strict criteria that you would normally see in an RCT. We wanted it to be pragmatic. So we had patients who were quite chronic, and you'll see that in the results in a moment, patients with quite severe upper limb impairment. Our only inclusion criteria is that they needed to be able to follow a one-stage command and have adequate vision to be able to engage in using the technology. So, and exclusion criteria, the usual stuff. So uncontrolled epilepsy, severe receptive aphasia, or severe cognitive deficits. So you can see that, or you can imagine that the cohort that we had come through is probably very much what you might see in practice, which I personally think is quite important in terms of how relevant this research might be to all patients. That's the paper. Now, okay. That video doesn't work, doesn't matter. This shows the flow of the study, the different assessments that we undertook at different periods throughout the study. So at baseline, we looked at function using the Wolf Motor Function Test, pinch and grip, the MAS, MOCA for cognition, ARMA for functional use, GAS for goal setting, EQ5D, FIM. So a really good range of outcome measures. The intervention that we delivered, we ran it in group sessions because that's a way we could afford to run this. We had up to 6 patients in each of those sessions. The sessions went for 60 minutes and participants attended for 12 sessions, and we wanted them to come in for a minimum of 3 times a week. So that's really reflecting some of those neuroplasticity principles. And we had stations with increased difficulty. So a workstation starting with very basic emerging technology where it might be gravity assisted and, very much, or, using a robot. So it could be fully compensated, all the way up to using devices that might assist with establishing a pincer grasp. And then we took a couple of post-intervention assessments immediately and at 6 months. This is what it looked like. This is some of the equipment that we used. So you can see we've got at the top left side, it's a giant mouse, which is exactly as it says. It's a giant mouse. We've got a bilateral joystick, which requires a little bit more from the patients in terms of some, anti-gravity movement when we're looking at shoulder flexion, and also requires some elbow control. And then we've got things like the Sabo rejoice, and we've got the Armio power as well. So we were very lucky to have this equipment, which we inherited, borrowed, and got some very small grants or established some relationships with the university to be able to get them to fund some of this equipment. So I'll repeat what I said earlier on. None of this was grant funded at this time. We really just managed to cobble this together with, through our relationships, a bit of begging and a little bit of media attention until we could get a little bit of grant funding. And so this is in 2016 that we evaluated it, but it's been running for quite some time. And I'll talk about sustainability in a moment. So this is just a snapshot of the first 100 patients or so that came through the clinic, came through the hand hub. We've had 500, 600, 700 that have gone through now. So it's been a really successful service for us. So mean age, 55.6, that's pretty young. We've got, obviously, it ranged from quite young, 18 or so, up to nearly 90 years old. The majority had a stroke, so 81% had a stroke. At presentation, 20% had some form of, generally was expressive dysphasia, some mild cognitive deficits. I mean, I think that this really reflects a standard stroke patient. 23% had attention deficits, so perhaps a form of neglect. And perceptual deficits, 20%. And this is a summary of the outcome data and some of our results, some of our measures there. We've got the modified Ashworth scale. And as you can see across the board, we had really incredibly successful outcomes. And bear in mind, I didn't show it on the page before, these patients, some of the patients that came through the door and attended the clinic were really chronic. So these are not subacute patients. Some of these patients were 10, 20 years post-stroke. So it's quite astounding to see that we could get such incredible changes functional changes as well. And you can see the p-values there and the effect sizes, particularly around the armour. The ability to be able to complete tasks and the impact that had on participation, societal participation. So that's quite impressive. And the EQ5D has a great effect size there as well. So this perception of overall health improving significantly was quite marked for this group. I'm going to very briefly go through this because I feel like I might be running out of time. Perhaps one of the most important take-home messages from this presentation, from an occupational therapy perspective, because this whole model happened in the occupational therapy department, is that it wouldn't have been possible without a partnership model. As I said before, we didn't have large grant funding for this. What we did have was a relationship with an engineering department who were really interested in emerging technology, and we were really interested in improving practice, and therefore made a wonderful relationship where we could catapult from funding that they had and pop it into our clinic and be able to do testing as we went along. And this is essentially I think a really great approach to translational research from an engineering perspective, where they're looking at basic things like algorithms and how we might test them, and wanting to translate it to humans, and where we have the humans that we can do the trials with. So this is essentially how it worked for us. We had our engineers innovating. And a good example was the development of that robotic device we talked about. And that was also supported through a relationship with industry that involved the university, not us. We just benefited from it. The translation to humans, so the trial of that EMU robot that I described earlier on with a variety of people, or some of the other robots we used in our hand hub, and then the capacity to be able to fund some of our clinical research. And I think that this is critical for, we talk endlessly these days, and I'm an implementation science specialist, we talk endlessly around the gap between the production of evidence and its incorporation into practice. And I think these types of relationships really have the potential to reduce that gap. We talk about 17 years to get evidence into practice. Certainly for us, we were able to change practice in a very sustainable and marked way within 12 months. And it gives us an opportunity to conduct practice-based research, which clinicians are interested in. They want to know, well, how can my practice contribute to knowledge in this field? Oh, that's it for me. Thank you very much. Oh, I think I stopped sharing.
Yes. Yes, thank you, Marlena. That was a very informative update on how occupational therapy can facilitate upper limb therapies in Australian setting where we have public hospitals. This is all public hospitals, so patients are not out of pocket. So that was really interesting. Nirmal, should we take questions now or after?
Yeah, there are a couple of questions for Marlena. Why don't we take?
Because I can't see them, so.
Oh, you can't see them. I will.
No, thank you.
So the first question is, please let me know the dose for the stroke patient using VR.
That's a great. That's a great question. It would be the same as it is for any patient that we're looking at who has a neurological impairment. The thing to be careful of with VR, with virtual reality, is that you want to first of all make sure that your patient has a tolerance for it, because some patients actually have quite low tolerance for virtual reality. It can really. It almost has that sort of, not a cerebellum sort of effect, but it can throw some patients out. But if they've got good tolerance for it, then incorporating that as part of your program and ensuring that your patient has adequate opportunity to practice the movements. So you need that time on task. You need to not just have somebody engaging in VR and just doing a couple of movements, because that's not going to be sufficient. So as long as they're actively engaging and practicing those movements and meeting that sort of dosage requirement, however you can manage that, whatever you can use to do that is fantastic.
But Marlena, you chose minimum 3 times a week, 60 minutes at least.
Yes, I did. I did, because that's, yeah. And I think that we found that that was in line really with what we're seeing in these large systematic reviews about what looks most effective for functional outcomes. I suspect that less than that, you're not having the intensity. So less than 3 times a week, if you know the patients who are coming in once or twice a week, unless they've got a really good home exercise program. But we also know that can be hard adherence-wise.
And Nirmal, just one last comment on this matter is that I think we would like to do more, but remember this is being done in a public hospital paid by the government, free of charge. So probably
Yes.
that's the max we can afford in terms of time and staffing costs and so forth.
We
But it
can
should
take
be
it
more than
forward.
that.
We can take it forward at multi-centric in the different countries. AOSNR can help you out, I'm sure. Then there's another question from Jabaraj who says, what is the optimal doses you would suggest to enhance the neural plasticity based on your clinical expertise?
You know, I'm going to say the more the better, honestly. But also bear in mind that I cannot say how important this task-specific training is, and we see that in animal studies as well. So, and I've seen that. Fari, remember when we did that study as well with orthotics, people with amputation. So making sure that something's engaging helps with adherence, but it helps with neuroplasticity. So as much as you can do, but I you know, if I'm giving a burst of therapy, I really want my patients to be coming in at least 3 times a week, and I would push for home exercise programs.
And just one last comment on that, and Stephanie, Nirmal, you guys know so much more about it than all of us. But I think one of the things is when you look at animal studies, for example, mice studies or spinal cord injured mice studies, for instance, and because Professor Mary Galea, one of our colleagues, has spoken about this in Bangkok with Witsanu's meeting last December. And, you know, when they talk about giving stimulus to those mice on those round wheels in the cages, there's a lot of stimulus for those mice. You know, whereas in a real human setting, the amount of stimulus we give is way down, way lesser we don't elicit enough neuroplasticity because of the intensity, the dosage is insufficient because we can't match that. So I guess just to keep in mind, more is less.
Yes,
Correct.
that's it.
Then there's a last question for you from Ishita, and I think questions are pouring. Can we use VR for ASD-based rehabilitation? If so, how?
Can I check with ASD? Do you mean autism spectrum disorder, or something else, or a myotrophic? Like, are we talking about motor neuron or just
No.
or autism?
Oh,
Yeah, it's
Or
autism spectrum disorder.
autism spectrum. Yeah, autism spectrum.
do you know? I was thinking about.
ASD. Yeah, ASD. Autism spectrum disorder.
Yeah, it's not my area of expertise. From a PEDS perspective, I've only really worked with children who have stroke, more so than ASD. So I really wouldn't feel confident saying, you know, how beneficial it might be. I'd have to really look at the literature.
I can comment on that. Again, we're adult physicians, so we don't deal with pediatrics. But when you look at autism spectrum disorder, it's a huge spectrum. You know, you could have, many of us may have it, but we're very mild and we don't even know we have it, right? And then you can have those very severe spectrums. You can sit anywhere in that spectrum. So really, with all these technologies, even basic ones without VR, you really have to look at the needs of the patient, the ability to comprehend, participate, have tolerance for that, and whether that's useful for them or not. So I reckon it's a big question mark. I would select the patients very, very carefully with the pediatric rehab medicine physician.
Yeah.
Thanks.
I can answer it. There is evidence to show that the cognitive, the emotional participation, and the motor responses, all three can be targeted with VR in ASD population, but not for severe ASD or mild to moderate ASD. There are cochrane review studies to show that it definitely helps.
Yeah.
But in mild to moderate population. Yeah.
But one has to understand that this is still a preliminary phase. The VR is still expensive in India and not being used at many centers. Maybe when low-cost VR is available in India, which we are working on, maybe another 5 years will come out with a proper kind of guidelines. Another question is, when shall we start the robotic rehabilitation post-neurosurgery?
I think that depends on what type of neurosurgery. So if we're talking about things such as, you know, spinal cord surgery, if you're talking about clot retrieval, obviously you want your patients to be stable. There's also, and we all know this as clinicians, that very hyperacute stage, we don't want to exacerbate fatigue. So there is that, we choose our time, to do the intensity of rehab. And in those first, 7 days or so is probably not ideal to be providing intensive rehab. And we know that from the larger VERT trial.
And there's a Vanchika is asking about what about cost effectiveness in Indian setting? Of course, we need to look at low cost therapy in our own setting, and we have to find out how we can provide the low cost therapy. Of course, we have been working, IFNR has been working to develop a lot of low cost. And for the hand function, we have developed a glove which is not very expensive and can be fit into 7 to 70 years. Galantino has launched it, which is also with FES. So we are developing a lot of low cost robotic therapy for the Indian setting, and maybe in future you could be able to get into them. So I think things are going to get better and better and better over a period of time. We are getting collaboration from various organizations and IIT industry, and I'm working on that with BCI also. I'm working. So we are definitely coming out with a lot of low cost equipment which are well certified by the IFNR, so that you know that they are going to work. Not that it's okay. So our team
And
is
can
all
I-
team is,
Yeah,
Yeah.
I was going to just add to that we also had a lot of restrictions in terms of finances. Like Fari said, public hospital really doesn't have a lot of money. So that's why we did things quite cleverly. We delivered it in a group. We had the staffing, we trained up our allied health assistants. We used a lot of low cost equipment. It was still TGA approved, but it was very inexpensive. So I think, the cost effectiveness, we actually did cost it at some point, it was very economical. I think people would be surprised at how cheap it was to deliver it in the way that we delivered it.
terrific. Wonderful. I think that's the way to go about. Stephanie Clark, you want to say some comment before I hand over to the chairperson for the next speaker?
Well, congratulations. That was a fantastic talk and very interesting and important field. I agree absolutely that we need to explore it, put it into clinical trial. And one thing which we always know, that among our patients, there will be those who respond to a specific treatment and those who don't. And we will need to determine what the precise indications are. But thank you very much. It was absolutely great.
Thank you, everyone. Thank you, Marlena.
Thank you.
Over to you, Ferry.
Yes, that was amazing. And thank you for all those good questions from the audience too. So we know you weren't sleeping. That's good. It gives me great pleasure now to introduce Dr. Neeraj Mishra. And Neeraj, there you are. He's a senior OT in the Department of Neurology in New Delhi and a lecturer and head of department in occupational therapy in Davangere. So thank you very much. We are looking forward to your talk about what your suggestions are in order to incorporate occupational therapy more and more with people with neurological injuries. Thank you.
So he's going to speak on targeted occupational therapy for different neurological disorder.
Thank you, Dr. Ferry, and thank you, AOSNR, for providing me this opportunity. I hope my slides are visible to everyone. So today I'll be talking about targeted occupational therapy for various neurological diseases. And the presentation will explore the exciting developments in occupational therapy, highlighting the innovative approaches that empower individuals to reclaim their independence and reach their full potential after neurological changes. So with this background, let me start my presentation. Is my screen still visible to all of you?
Yes, sir, it's visible.
Actually, I can't see my screen. Just give me, I'll just stop and share once more. All right, thank you. So modern day occupational therapy is very different from what it used to be in earlier times. And the reasons are that although the conventional therapy still holds good, the exercises, the activities, the ADL training, hand splinting, etc. But many newer approaches have come into the picture, and that has changed how occupational therapy is being practiced these days. So approaches like mirror therapy, motor imagery, CIMT, dual task training, all have added as useful tools to modern day occupational therapy practices. And with that, the blend of technology, like we saw in the earlier presentation, the presence of biofeedback, FES, robot-assisted therapy, augmented reality, and virtual reality, all have been combined together now. So the occupational therapy today is becoming more and more holistic and more client-centered. And as per the occupational therapy practice framework, the focus still remains on the performance skills, holistically concerns about motor and praxis, sensory perceptual abilities, cognition, psychosocial aspects, and emotional regulation. And the outcome that is planned to achieve by all these interventions remains to improve the occupational performance, increase the role competence, improve the quality of life, and the overall health and wellness of the patient. The occupational therapy task-oriented approach was a major shift in the focus of how occupational therapy is being practiced. Earlier, it used to be a generalized therapy in which there was a set of activities or exercises which was presumed to fit for all things. But eventually, this approach is more of an occupation-based and a client-centered approach in which the exclusive interest and the needs of the client is taken into consideration, and where the activity will be performed, the environment of the patient, and what are the valuable occupational roles are being taken into considerations. So these principles are compatible with motor learning and motor control principles, and it requires intensive motor training for functional activities up to 8 to 10 hours of the waking hours, requires lots of variable practices in different environments, controlled environment, non-controlled environment, and also various degree of gradation needs to be there from easy to difficult, with just the right amount of challenge given to the patient to motivate him towards further success. There has to be intermittent feedback mechanism so that you can reflect upon the performances and improve in the subsequent attempts. And with this, we'll talk about constraint-induced movement therapy with these days, which is used as a common adjunct to occupational therapy, and which requires the forced use of the CIMT involves constraining the unaffected limb and forcing the individual to use the affected limb. Now, what we have to do? We have to do repetitive practices. The patient engages in frequent repetitive exercises, which helps in reorganizing the circuits in the brain and train the brain to control the affected limb. And what kind of activities are chosen for this are the functional tasks that the patient would be doing in his day-to-day activities. Like you can see in the photographs, like transferring objects, like filling a glass of water, cutting a piece of bread. What it does, it encourages the patient to have a more realistic expectation about his abilities and helps him gain more confidence about his ability to engage into a valuable occupation that is very exclusive to him and as per his need. Also, another aspect these days that is being worked is dual task training, which works upon enhancing the multitasking abilities of the clients. Now, it involves two different things. One is a motor task that should be a physical activity like standing, walking, or treadmill walk, or reaching for objects. And at the same time, there is a cognitive task that is added, which could be an object naming, letter reversal, number cancellation task. And these two tasks are done simultaneously. The research evidence says that this has found to be helpful because it says it mimics day-to-day activities. Very rarely are we doing activities which require only motor inputs or which require only cognitive aspects. But when both are combined together, it has been found to be very helpful in by the virtue of putting a cognitive load on the brain. That is, it combines the physical activity with the mental task, thus challenging the brain to multitask. And what it does in turn, it has the research evidence is there that it improves the coordination, the balance, and the reaction time for performing the task simultaneously. And as I said, it prepares the individual for transition for multitasking into the real world. How he was before the onset of the impairment, the things that he could do before his impairments required him to use both the abilities simultaneously. So when he is practicing both the tasks together, then the functional outcomes are found to be much better than only motor tasks given separately. Another intervention that is very commonly being followed in occupational therapy is mirror therapy. And this harnesses the power of reflection. So what is done in mirror therapy? We put a mirror in front of the unaffected limb, and a mirror creates the illusion of a functional limb, tricking the brain that it believes that the affected limb is moving. So all the activities are performed by the non-affected limb, but the illusion into the mirror makes the brain think that the affected limb is being utilized, and all the day-to-day activities, the ADL task that the patient routinely does is practiced by this method, and it has been found that it helps in rewiring of the brain circuits, and the neuroplasticity is improving, and overall the motor functioning of the limb has been found to improve by the use of mirror therapy in stroke patients. Not only this, the best part about mirror therapy is that it has been found to be a feasible method for training post-stroke impairment, wherein motor, sensory, and perceptual deficits, all three can be worked upon in acute, subacute, and chronic phases. So it is not just limited to any one phase of recovery, but all three phases, and many domains can be simultaneously taken care of by the use of this. If we include bilateral arm training along with mirror therapy, research evidence again says that there is an improved outcome when we do it just by a single hand. Now, this is another very new area of practice that is being followed for neurological rehabilitations is motor imagery, mental practices, and action observation. This all rests on the understanding that the brain centers that are being activated by doing the actual movement and by just imagining the movement or mere visualization of the action, all three have been now proved through scans that stimulate the similar areas of the brain. If you can see in this picture, you can see the areas that were excited when the person was just doing a movement, and a similar area is being excited when he is just imagining about the movement. What this has done is it has opened a big avenue for practice of exercises and practice of activities in occupational therapy, wherein the patient, even if he is not actually having the set amount of muscle power to do the action in reality, he can just imagine the movement, and result shows that when used in conjunction with conventional occupational therapy for functional rehabilitation, both upper and lower limbs, as well as for the recovery of daily activities and skills, have been shown to improve a lot by the use of motor imagery and mental practices. So this involves mental rehearsal, wherein the patient vividly imagines themselves performing a desired movement. So for example, he is sitting and he wants to take a glass of water, example, and activating the brain regions involved in motor control. This leads to neural activation by stimulating the neural pathways similar to the actual movement, which would have happened if he was doing it actually, promoting neuroplasticity and recovery. And the functional gains has been shown that regular practice has enhanced the overall functional capacities and improved the muscle picture and coordination in the individuals. Now, there is also an arena in occupational therapy wherein we have to work on cognitive and executive functional rehabilitation, mostly when persons are having traumatic brain injury. In such cases, it has been found that working on attention and memory, problem solving and decision making, and planning and organization all have to be taken care of simultaneously apart from the motor aspects. So occupational therapists address attention deficits and memory impairments through strategies like use of memory aids, environmental modifications, and task simplification. These act as an additional support to the clients. We'll be talking about details about them in the next slide. so that the patient is able to become functional with whatever limited capacity of cognition that is left over with him. And at the same time, we can continuously keep upon improving these things. Also, activities like role playing, simulations in real life, and structured problem solving exercises enhance these skills further. Therapist also teaches self-regulation techniques. Now, you can see in the picture, a simple activity like planning a meal together helps in the planning ability, or planning to have a conversation will help in the attention. Just requesting the client and helping him in tidying up a room will work upon his organization skills. So when we are working on the traumatic brain injury clients, we have to work upon simple activities which are again as per the interest of the clients, but which will be helpful in improving their problem solving and decision making abilities. Also, to better ensure the planning and organization capacities of the patient, occupational therapist guides individual in developing routines, time management skills, and strategies to break down complex tasks into manageable steps. So activity analysis is done. The task is broken into simpler steps, and one step at a time is taught to the patient so that he can master each and every step and eventually learn how to complete the task successfully. Now, this training can be done on a paper pencil, or it can be done by therapeutic activities. And of late, it is more often being done on the computer system. Technology has come to the rescue. And now we have many different softwares, many different applications through which you can work upon memory, and they address upon memory issues, including difficulty in remembering information, recalling events, and learning new skills. Also, there are games which require you to focus attention and try and touch a dot that is blinking on the screen, try and cancel a certain thing that is visible on the screen, and it helps in improving the attention and concentration, and also ability to filter out distractions. Some studies have also proved that cognitive rehabilitation has actually helped individuals with communication challenges by the virtue of not only improving their speech, but understanding of the speech and improving their reading comprehension. One more benefit of these activities are that it improves the problem solving abilities of the clients, enhances their reasoning skills, decision making abilities, and ability to think flexibly and creativity to the solution. Now, what happens is these programs are graded in such a manner that you can choose the level of the current functioning of the client, what are his cognitive abilities at present, and then you can customize the programs as per his needs, and then one by one you can grade the activity as and when the client shows improvement and go to the next level. Similarly, for dementia, there are many compensatory strategies for memory impairment in dementia that is being used these days. One of the very newer things that is being practiced these days is the use of a Snoozelen room. A Snoozelen room is a therapeutic environment created for the express purpose of delivering high levels of multi-sensory stimulations. So it gives stimulations in the form of visual inputs, it gives stimulation in the form of audio inputs, it can give in all other different sensory inputs. What it does, research says that it works on the activation of the reticular activation system, and overall awareness of the client has been found to improve by the use of Snoozelen room. These rooms can be made at a very high cost also and at medium cost also, and can be practiced easily at various setups. Also, because the persons with dementia are having problems with memory, simplification of environment, such as removing of the clutter, decluttering the room, labeling items very clearly, using color-coded signals will help in organization and help them to maintain their activity levels in spite of being whatever problems they have due to dementia, and they will help them to remain functional for a longer duration of time. Plus, this, when added with some degree of cognitive training in the form of brain stimulating activities such as paper puzzles, games, or memory exercise to maintain cognitive and memory skills. These activities, again, as I said, can be paper pencil based, can be in the form of activities as a tabletop activity, or it can be on a computer interface, depending upon what kind of setup you are working in and availability of resources to you. We can also use memory aids in the form of calendars, notebooks, or reminder apps, which can help in keeping a track of appointment and different tasks and important information regarding their important schedules or regarding their money management or other things. So a certain amount of external support, a certain amount of modification into their existing environment goes a long way in helping to maintain the functionality in patients with dementia. Biofeedback is another technology that is helping in occupational therapy provision these days. And what it does, it uses various kinds of sensors to monitor the physiological signs. So the physiological signs of the body, like the heart rate, muscle tension, or brain activity, can now be visualized, and there will be a feedback that comes to the patient in real time. And once he gets these visual and auditory feedback, he tends to gain a conscious control over these physiological responses. So imagine a patient having anxiety, imagine a patient having panic attacks. And when he has these kinds of biofeedback mechanism ready for him, it helps him to gain a conscious control of these responses. And thereby it helps in promoting relaxation, reducing the stress, and overall improvement of functioning of the patient. One more approach that is being used these days is functional electrical stimulation. Now, in this, a mild electric current is used to stimulate the nerve, and the patient at the same time is used to do functional activities like holding of different objects, transfer of objects. This stimulation has been found to help in strengthening and retaining the muscles weakened by neurological conditions. And research says that it helps in enhancing mobility, reduces spasticity, and provides a better control over the affected limbs. As the earlier presenter was telling us, virtual reality and augmented reality again have been proved to be a game changer in modern day neurorehabilitation. And the occupational therapists are now using the tool of virtual reality and augmented reality to create an immersive, engaging, and highly effective treatment experience for their patients. This provides them an opportunity to work even under controlled environment, but simulation of the real life activities, working in a kitchen, simulation of going to a marketplace, simulation of being able to cross the road, simulation of driving skills. All this can be done just in front of you on these systems in the comfort of the clinic, which is a very controlled environment. And once the patient is able to do these things in this controlled environment, it is easier for them to be motivated to try this in the real world. So virtual rehabilitation survivors, can practice reaching and grasping objects in a virtual kitchen, or trying to take out many medicines from a shelf, or take out filling a trolley in a virtual market arena. So all these things give them a practice of the real-time scenario, and generalization of skills is found to be better. Overall, it has been found that these are helpful in memory issues, attention deficits, and improve in problem-solving difficulties. Plus, motor functions have also been found to improve, and functions have also been found to be improved in various researches using virtual reality. Robot-assisted therapy already has been discussed by the previous speaker. Yes, robotic-assisted rehabilitation can potentially increase the efficiency and accessibility to therapy by assisting therapists to provide consistent training for extended periods of time and collecting data to progress. Now, one important thing that is going to start, already it has begun, and over the years it will grow, is the possibility of using of robotic assisted therapy in telerehabilitation. See, now COVID has given us an idea about what telerehabilitation wonders it can do. So with these devices, which are remotely located, if it can be operated from some person in some other part of the geographical region, it could be a game changer to providing occupational therapy services at any part of the world by anyone around who is having control of these systems. So this could, again, it is a new arena, lots of research is going on, and we expect more and more newer studies to come up telling the benefit of these. When we talk about traumatic brain injury, it gives us a unique scenario wherein the functional capacity, the mobility, and the cognition all might be affected at the same time. So then you require to work on different aspects for the same client, in which some part is of your work is on functional training and on balance and coordination, working on reaching task, object transfer, standing, holding different object, dual task training like we discussed earlier, and use of task-oriented approach eventually will help the patient in regaining functional abilities, balance, coordination, and ensure safety of the movement. Plus, ADL training with the help of adaptive equipments, hand splints, and assistive devices such as modified utensils or adapted grip handles and other tools help them to ensure that they are able to perform their ADL task independently or with minimal amount of support. Transfer skills needs to be trained for these clients because there is chances of impaired mobility here and chances of fall are very high. So regular transfer training from chair to bed, chair to shower, everything has to be trained. And again, various devices are there to help you. And environmental adaptations. One is for safety, another is for fall risk prevention, and third is if there is a cognitive deficit, it will help in modifying the environment which will be full of helpful cues and which will be decluttered so that the distractions can be minimized and the patient can focus better on the task that he is doing. Similarly, in Parkinson's disease, assistive technology is coming to our help apart from the conventional exercises about their balance, about their hand functions, about their overall posture. There is a requirement of mobility aids which can be given as and when needed. Many times what happens, we are reluctant to give a mobility aid, but if provision of a mobility aid ensures the safety and comfort of the client, then it motivates them to try and go for more functional community-wise, be more functional community-wise. Also, there are certain devices like reaching devices and dressing aids, which can help them to continue these tasks in spite of having various amount of tremor in the hand or various amounts of poor control in the hands. Plus, at the later stage, they might require medication reminders and also automated pill dispensers, alarms or apps, which help them in maintaining their medication schedules. So all these can be designed by the prescribed by the occupational therapists. Occupational therapy for spinal cord injuries, another area in neurology which lots of OTists are working on. And the main areas to focus here are again the positioning and transfer training, because pressure source and deformities are two big culprits that are bound to happen. So the more intensive your therapy is, the more regular your therapy is, you will be able to prevent these things. At the same time, transfer technique needs to be taught depending upon which level of injury is there, so that as soon as possible, community mobility with help of whatever devices, wheelchair or a specialized device or a specialized modification for driving, anything can be ensured. Bowel bladder training needs to be done, hand function for higher lesions, and bed mobility needs to be trained. Also, try and use the external support in the form of splints, adaptive devices, assistive technology, and robotics of late, so that more and more amount of community mobility and driving can be ensured as soon as possible. There is one more growing area of interest these days about functional neurological disorders. Now, functional neurological disorders is characterized by symptoms of altered voluntary motor or sensory function, with clinical findings providing evidence of incompatibility between the symptoms and the recognized neurological medical condition. It is a difficult condition to diagnose. Once diagnosed, it is a difficult condition to treat. Symptoms are very diverse and can include weakness, movement disorder in the form of tremors, jerk, dystonia, sensory symptoms, cognitive deficits, and seizure-like events, which are called dissociative seizures or non-epileptic seizures. At our setup here, we get lots of such clients, mainly who are children or females, young females, who will present with significant amount of presentations of seizures, loss of consciousness for n number of times in a day for a prolonged duration. But when you test them, the EEG is normal. The deficits do not match with whatever the patient is presenting. So for these patients, research says that stress has been found to be one of the major cause for precipitation of this, and education about these functional neurological disorders to the client, making them understand what is happening with them and how it is correlated to the stress, and help them in managing their anxiety, improving their coping skills, and provide relaxation techniques and diversional activities has been found to be helpful in management of these clients. So overall, the idea these days is to go for a synergistic approach. Just don't remain for the conventional exercise program. Add to it with whatever is possible. If mirror therapy is required, combine with occupational therapy for motor recovery. If biofeedback is needed, combine it with cognitive rehabilitation to improve attention self-regulation. If you have a facility for virtual reality, add CIMT and FES with this for in this immersive engaging therapy. And then what you have to do is finally that you have to ensure that the approach is very personalized. It is very client-centered. All clients are different. Their needs are different. So tailor interventions, that is individual needs of the goals. Remember what are the abilities that are lost and what are the abilities that are remaining. So those that are remaining can be used to compensate for those that are lost. Those that are lost or have been impaired can be improved. And then technology comes in to support you along with your day-to-day exercises, integrate virtual reality, AI, robotics as and when required, and think of holistic care, combine physical, cognitive, and emotional support. And overall, what this will do, it will turn them into empowered individuals, increasing their independence and overall good quality of life. That's all from me. Thank you so much.
Thank you very much, Neeraj. That's a very comprehensive overview of the multitude of, I suppose, the armamentarium that occupational therapists have for this range of neurological disorders. And before I hand over to Nirmal, because I can't see the questions, I just wanted to make one comment about the functional neurological disorders. And I don't know about India, but we've got an epidemic of that here. And I think post-COVID, it's become even worse. And I always worry about the trainees are registrars, for example, where, we tend to call them conversion disorders, and they're not deliberate. The person isn't deliberately doing it. It's just the way the brain is interpreting their stress, which manifests in a way where symptoms and signs are not consistent with what they should be, what should be happening. So my question to you was that, do you have much success in this group? Because we don't.
So as a
Actually,
neurologist,
sir, please.
I see almost 1 to 2 patients every day.
Wow.
So this is quite common in even the young children to the young female, mostly in the children and female, as rightly pointed out by the Neeraj. And there's always some background of stress, particularly in children, is school, the teacher relationship between the colleagues and the other students. So that's there. But in female, there are a lot of other issues, particularly in the family, stress. I had just admitted a patient for 24-hour video monitoring who was getting 6 to 8 attacks of epileptic seizure, so-called. But they were very funny. So I did a video EEG and she's nothing. And she was on 4 anti-epileptic drugs. In fact, I stopped all the drugs before doing the EEG. And now I'm not put on any drugs. So she's about 40 years. So we see very regularly, it is only that we need to open the eye. Many of these patients continue to get one add-on to another AED. So I had patients who are on 5 AED and getting the attack, and they were actually non-epileptic seizure as well. And they really require counseling, the psychological support, talking to the family. And, sometimes we have given they come with the leg weakness, not able to lift the leg or hand weakness. We have used even FES to, get the things out of that. So these are challenges, but it requires, again, neuro counselors, psychiatrists, neurologists, therapists, all have to done. We had a patient with voice, not able to talk without any neurological disorder, and then we have to stimulate the vocal cord and get the things out. So these are the challenges which we face every day. There are a lot of questions, Neera, for you. What about neuromodulation, non-invasive electric transcranial, that is TDCS, and can the TDCS and mirror therapy can be used together?
Yes, there are quite a few studies now which are working on these direct intracranial stimulations. At few centers in India also we are doing this. And there is a study, I think, going on in AIMS, wherein they are working on this transcranial stimulation along with CIMT together. So yes, it is a promising avenue, which is still under process, and it is not routinely being practiced at all centers. But eventually, once we have a good amount of research evidence for this, this could be a part of the day-to-day rehabilitation practices.
So I must say that TDCS or ITMS are still not full-fleshly being practiced in our country. There are some people who are doing as a research and or treating. There's only limited number of indication at the moment. Most of the studies are into the research. Like we got 2 studies funded by ICMR on TCDS. We are going to evaluate 1-year follow-up tomorrow on Monday. So these are kind of studies which are under the funding and research. But you can always, if you have the zeal to do the research, you can always do it. They are definitely useful. There are evidences, and we need to have our own evidences in our own country, whether it be in India, which Sanu has also a lot of access to both RTMS and TCDS. He can put some highlight on that in his country.
For neuromodulation in Thailand now, I think it's also is like the new area for exploration in terms of to help promote recovery in terms of like under the concept of interhemispheric inhibition between both sides of brain, but also there are many ideas to create that in terms of brain lesion, and also that the indication that we use in for psychiatry, like depression, that is like a new intervention in terms of refractory test of a major depressive disorder that not respond to the oral medication alone, and sometimes the psychiatrists they do that, but also we know not exactly know the real benefit, but we know it's a big hope. And also today we're talking about the OT that a lot of intervention that try to improve recovery and to promote the function in terms of restoration. But what we don't say today is about prognosis of the disease, because everything that we're talking about with various intervention, even conventional or robotic, we try to improve training effect in terms of the quality and quantity of treatment. That means that the dosing that Marina has mentioned, that sometimes we don't know, but what we forget is the neural substrate, the severity of the disease in the brain or the central nervous system, because for the one who have a severe case,
Signals
in
are
my
poor.
idea, whatever intervention we try to put is loose, because the brain substrate, the neural substrate is lost. So we never get that. But in terms of for my severity or moderate severity, you can see a lot of effect of neuroplasticity. That we need to think about that as well. That I try to let you know and buy this idea. Otherwise, we will put full effort without any reward to our patient. That what my thinking that I want to share.
Thank you. There is a question from Aman who says, out of conventional new and technology, which would be the most suitable approach for acute stroke patient and MND?
See,
Neeraj.
actually, as I told you, the interventions that you choose will depend upon what is available to you. That is very important. You want to use a technology, but it is not available at your center. You won't be able to use it. So conventional therapy will always remain the cornerstone of thing. The approaches which require less amount of technological assistance or tool use will still be there. So you have to start with that and in the acute phase, and then depending upon what kind of infrastructure you are working in, you will have to put in the technological advances, whatever is available to you. If it could be as simple as a mirror therapy, which was used, and it can be very readily be available anywhere, and it could go to a robotic assisted. So again, it depends which setup you are working in and what is available to you. But the conventional therapy and the newer approaches, which include the CIMT and all, can easily be practiced at any center.
I think I agree with you that whatever is available to you, you have to use that to the best of the possible. Abhishek, you want to add on to that something?
Yet, a lot of technology has come in last 15, 20 years. The commonly used are FES and robotics primarily. But as Neera just told, 80% of patients don't require technology. Only those who have severe involvement will require technology. So if you have a good team which can deliver tailor-made programs for a specific patient, what he or she requires with a conventional approach, and add-on technology as and when required is the need of the hour. Technology alone in itself is actually of no use. If you only can get more movement with technology. You learn the skill in conventional therapy. That is a cornerstone. So better to focus on conventional therapy and add on technology as and when you can be able to manage the finances and the cost for that.
Thank you. There's one more question for you. Other than the assistive adaptive devices which you mentioned, is there any new technology or intervention for stroke survivor with vision or the gaze impairment?
Well, I am not aware of, to be very honest, I am not aware of any other technology other than the assistive technology things you have said. So I think if someone else in the panel would want to answer this, so please.
Yeah.
There are
There
the
two.
newer tools for the visual rehabilitation, and they are available. There are definite ways to stimulate the loss of vision or the gaze hemianopia, and we have been using them. Abhishek can add on to
I
that.
think one is called as Vision Coach. It's very commonly used. Vision Coach is just nothing. If you have a big computer screen where signals come from all over the sides. That's all. Again, there are computer-based programs where you can try to increase the gaze deviation with that. So these both are software-based applications which can be used with conventional approaches also. You can make a board and keep on adding extra inputs from the involved side. But computer-based programs are also available both for gaze as well as for hemianopia, but they are not mandatory, not necessary. A simple training from the involved side also works equally well if you can provide enough repetitions of that.
Stephanie Clark is here. She is expert on the visual rehabilitation with the prism adaptation. Madam, would you like to comment? You have been absolutely expert into that field.
Ma'am, please unmute yourself.
As my colleagues just
Dr.
said, it's
Stephanie Clark.
hello. This is a very difficult field because there is mixed evidence, and patients have lost their vision in part of the visual field because of different types of lesions. And the site of the lesion determines to a certain degree whether they will recover or not, even after rehabilitation. And as pointed out, this is an ongoing research. But as also said before, it is worth trying because patients improve, whether it is by attentional aptitude in order to learn to wait saccades into the scotoma. It's already one thing which is very helpful in everyday life. Yes, well, I will be short.
Thank you. Then there's one more question for you. The meditation plays an important role, specifically transcendental meditation, in managing stress and neurological disorder due to any cause beside all therapeutic. I think this is okay, but this is not a part of our rehabilitation strategy one can always do is stress can be relieved. So I think we'll skip that question. If we have technical techniques available, which one to go for?
So
So
go
whatever the
for
evidence based, Neeraj, tell them.
Yeah. So if you don't have a problem with availability of technology, then you use whatever is available for you, which has got a good evidence backing. Don't try anything just because it looks fascinating, but try those things which has got a good body of evidence to support. And then if you don't have a problem with technology, go ahead and use whatever you want. Only thing, it should have a sound backing by a good clinical amount of research. Thank you.
Just to add that I think mirror therapy, CIMT, bilateral arm training, upper limb robotics, especially the newer ones with distal approaches, FES, virtual reality, all have some evidence, especially in stroke patients, in Cochrane review. But not for every patient, but patient will benefit out of them. So for significant severe strokes might not change whatever you do, but moderate to severe strokes can definitely change if you combine technology with conventional rehab.
So at the last leg, Professor Tisa has joined. At least we can see his face now. He may show us. So that closes our questions. So Abhishek, would you want to highlight on the next webinar on 7th November, which is going to be on speech and and swallowing therapy?
Yeah, the next webinar, which will be on 7th of November, will be on speech, language, and swallow rehabilitation. There will be 2 talks, one on speech therapy approaches, one on dysphagia. We will tell the speakers in few days' time. And I'd like to thank both the speakers for their brilliant talk. Professor Ferry Khan for chairing the session with Dr. Vitsano, Dr. Surya for motivating us and doing the moderation for all the talks. I hope Tisa has joined. Hi, Tisa, how are you?
Hi, Abhishek. Sorry, I had a conflicting meeting that came up last minute.
So anyway, you came in at last second while train was about to leave. So we would like you to say a few words about the webinar. Of course, we had a wonderful session. More than 160 people were there. And we had plenty of questions for both Eileen as well as for the Neeraj.
Excellent. So I missed it, Nirmal, but I'll watch it. You send me the YouTube link, so I'll go back and watch it cautiously. And you are doing great work, not only for India, for the region also. And I look forward to supporting you in every possible way as best as I can.
Thank you.
Absolutely.
Thank you.
Absolutely. So we look forward to all of you into the next webinar, guys. So thank you very much. Namaste.
Thank you very much. Bye-bye. Thank you.
Bye.
See you soon. Keep on interacting. Thank you. Thank you, Smita.
Thank you, sir.
Thank you, sir.
Thank you very much. Bye-bye.
Thank you, everybody. Bye-bye.